Welcome back to The Deep Dive, the show where we turn essential foundational knowledge into immediate clinical insight, tailored specifically for you, the medical learner.
Glad to be here.
Today, we are undertaking a really critical mission, getting into Chapter 8 from Basic Geriatric Nursing. It's all about health assessment for older adults.
And this chapter is, well, it's pivotal. It really drills down on one central truth, assessing an older adult. It's just not the same as assessing someone younger.
Right.
The core challenge, and the book calls this out, is that illness often presents in ways that are subtle, maybe vague, or what the text calls atypical.
So our goal today is to give you a really comprehensive, structured way to collect data that actually accounts for those unique challenges. We need to figure out who needs a closer look, who needs further evaluation. Assessment isn't just one thing, is it? It's kind of a spectrum.
Absolutely. Yeah, you've got, at one end, simple health screenings. These might even be done by lay individuals, checking blood pressure at a health fair, maybe screening for falls risk, or looking at basic challenges with activities of daily living, ADLs.
Okay.
The main purpose there is really just triage. It's about identifying the folks who need that next, more complex step.
And that step is the in-depth health assessment, the kind performed by skilled professionals like nurses. So to do that properly, we've got to start with the basics, the language of patient care, data types. What's that key difference between objective and subjective data?
Okay, so objective data is the stuff you gather using your senses, what you see, hear, touch, sometimes smell, and importantly, it's information that others can verify.
Concrete things.
Exactly, concrete, like seeing a rash, noting the color of wound drainage, or, getting a specific blood pressure reading. And the text emphasizes precision here. It's not enough to say the patient feels warm.
Yeah.
Need to use a thermometer, get that specific verifiable number.
Makes sense. Versus subjective data. That's the patient's internal world, right? Their feelings, their point of view, things you can't really measure from the outside.
That's it precisely. This is where we capture things like pain, anxiety, maybe frustration, fear. The patient telling you, for instance, I feel so dizzy every time I stand up, or maybe I'm worried about who's going to take care of my dog while I'm here. And it's crucial. Absolutely crucial to capture this in their own words as much as possible.
So once we know what kind of data we're after, we need to know how to actually get it. And the interview process itself, well, it needs some specific tweaks for this population.
Definitely. Let's start with just the physical setting. It sounds basic, but it's more than just comfort. It's about minimizing interference. You need a quiet room, turn off the computer sound, silence the phones if you can, reduce glare from windows, which can be really disorienting for older eyes.
And here's a really practical tip the book mentions, something easily overlooked. Because urinary urgency and frequency are so common, make sure the patient has immediate, easy access to a restroom. Right there.
That simple thing, it speaks volumes about respect, doesn't it? And helps with cooperation, too.
Totally.
And that leads right into building rapport. The QSEN safety focus in the chapter is clear. Always address the person formally, Mr. Singh, Miss Hernandez, unless they specifically ask you to use their first name.
Right, assuming first names can feel presumptuous.
It often does. It can feel disrespectful.
Yep.
And you need to explain the purpose of the interview, how long it might take. That helps reduce anxiety.
And we have to respect their pace.
Yeah.
You just can't rush geriatric interviews.
No way.
Speed of recall, even just verbal response time, it can be slower. And honestly, one long marathon session. It's exhausting for the patient and, frankly, for the nurse, too.
Absolutely. The best practice, really, is to aim for several shorter interactions, maybe less than 30 minutes each, rather than one huge, overwhelming assessment.
Good advice. And when you're speaking,
keep it slow, keep it clear, simple language. We absolutely have to dish the medical jargon and abbreviations. Patients don't know what NPO or CHF means usually.
Right.
And this one can be tough, I know, but try not to interrupt. Even if they seem to be rambling a bit, let them finish their thought. You can always gently guide them back on track, maybe by summarizing what they've just said.
Okay, that makes sense. Now, something we often encounter, family members being present, sometimes they jump in and answer for the older adult.
Oh, yeah, that happens a lot. And while their input can be valuable, the nurse really needs to tactfully redirect. Gently ask the family member to let the patient answer first, unless, of course, the patient is clearly confused or unable to respond.
That family dynamic also brings up a really critical safety point the chapter highlights.
Which is?
Using family members as medical interpreters. The literature strongly discourages it.
Oh, absolutely. The risk of getting things wrong, misinformation, misinterpretation, it's just too high. Not to mention potential breaches of confidentiality. It's a risk we really shouldn't take.
Definitely not. So once we've gathered that detailed health history, and that covers a lot, right?
Yeah.
Identifying data, past history like allergies, immunizations, current problems, meds.
The whole picture.
Right, the whole picture.
Yeah.
Then we move to the physical assessment. This is where we try to validate some of that subjective history with objective findings.
And prep here is straightforward but key. Keep the patient warm. Older adults chill easily. Drape them appropriately for privacy and warmth. And have all your gear ready before you start. Stethoscope, scale, thermometer, everything.
Save time and keeps things moved.
Exactly. And the assessment itself should follow a logical flow. Head to toe is common, or maybe a body systems approach, or even functional. You start with a general look and then get more specific.
Let's touch on the 4 main techniques, but focus on those geriatric adaptations. First up, inspection.
This is your go-to. It's continuous, starts the second you lay eyes on the patient. You're using vision, smell, hearing. You might notice something general, like maybe their gait seems a bit off. And that observation then directs you to inspect more closely. Maybe look at their feet, assess their muscle strength, or do a quick neurocheck.
Got it. Second technique, palpation, using touch.
Right, using those sensitive fingertips to check pulses, skin temperature, texture, look for masses, or pinpoint tenderness. But here's the crucial adaptation for older adults. Always use light touch first.
Why is that so important?
Because their skin is often more fragile, tissues are less resilient. Deep palpation right off the bat could actually occlude a blood vessel or just cause unnecessary pain. So be gentle and standard practice. Palpate any painful areas last.
Okay, light touch first, painful areas last. Makes sense. Third, auscultation. Listening.
Usually with a stethoscope, yeah. Listening to those internal sounds, heart, lungs, bowel sounds. And we need to be good at describing what we hear, using terms like the quality, is it crackling, the pitch, high or low, intensity, loud or soft, duration.
Getting that description right is key for communication.
Absolutely. And finally, number 4 is percussion, tapping on the body surface.
This one seems less common for routine nursing assessment.
It often is. It involves tapping to listen for resonance or dullness, which can tell you about the density, size, or position of underlying structures. It's a useful skill, but it takes practice, and the chapter notes nurses use it less often than, say, inspection or auscultation in daily practice.
Okay, now let's shift to what might be the single most important concept from this entire chapter. If you get this, you're well on your way to being a great geriatric nurse. It's the atypical presentation of illness.
Yes, this is absolutely critical because the standard signs and symptoms, the classic alarm bells you learn, they might be completely missing in older adults.
This is where that strategic knowledge really comes into play.
Exactly. Take infection, for example. You might see a total absence of fever, their white blood cell count. Could be well within normal limits.
Why is that?
It's often due to a lower baseline core body temperature and just a less efficient thermoregulatory system as people age. So here's the crucial insight. A temperature change of only a few tenths of a degree, maybe going from 97.8 to 98.4 Fahrenheit, that might be your only sign of a serious infection.
Wow. So you're not waiting for 101 degrees. You're looking for that subtle shift from their baseline.
Precisely. Or think about cardiac problems. That classic crushing chest pain might be completely absent.
So what do they report?
It could be really vague stuff. Unexplained fatigue that just hits them, maybe some nausea, shortness of breath, what we call dyspnea, or perhaps just fainting syncope, very nonspecific.
Or an acute abdomen, something serious, maybe needing surgery.
Right. Instead of agonizing pain, it might just present as sudden loss of appetite, anorexia, or maybe just mild, vague abdominal discomfort. If you dismiss that because it doesn't fit the textbook picture of appendicitis,
you could miss a crisis.
you could miss a crisis, yeah.
This need for adaptation flows right into measuring vital signs, too. Let's talk temperature rounds. Oral seems easiest.
It often is, but yeah, it can be tough if the patient can't cooperate or if they don't have teeth, making it hard to get a good seal.
Okay.
And we have to remember the big warning about the rectal route. It can be psychologically distressing, quite traumatic for some, and it's actually contraindicated if someone's having an acute cardiac event because it can stimulate the vagus nerve.
Good point. What about pulse?
Radial pulse is common, yeah. But be aware, the arteries in older adults might feel stiff, maybe even a bit knotty, because of decreased elasticity. So palpate gently, don't press too hard.
And if the radial feels weak or irregular?
Then the apical pulse, listening right over the heart for a full minute, that's considered more reliable. and be alert for a pulse deficit.
Define that for us.
That's when there's a difference between the apical rate, listening at the heart, and the radial rate, feeling at the wrist. If the apical is faster, it might suggest the heart's beating but not effectively pumping blood out to the periphery. Could indicate vascular issues.
Okay. And checking pulses further down, like in the feet.
Essential. But those peripheral pulses in the lower extremities, they might be weaker, diminished, sometimes even absent because of arteriosclerosis, hardening of the arteries, which is common. You might need to grab a Doppler device to actually hear the pulse if you can't feel it.
Good tip. Let's talk respiration.
Okay, so the depth of breathing often decreases a bit, partly due to changes in the chest cavity shape over time. But the rate itself, normally 12 to 20 breaths per minute at rest, that can be an early clue too.
How so?
Interestingly, a decreased resting respiratory rate, maybe dropping below 12, can sometimes be an early sign of an oncoming infection, even before you see a temperature change or other symptoms.
Wow. Okay, a lower rate is a warning sign. That's counterintuitive.
It can be, yeah. Worth keeping in mind.
Finally, blood pressure. Equipment setup is key here, isn't it?
Hugely important. Never just grab any cuff. Using one that's too small will give you a falsely high reading, but using one that's too large can give you a falsely low reading. The rule of thumb is the cuff width should be about 20% wider than the diameter of the person's upper arm.
Get the right size cuff. Got it. And what's the threshold for reporting high blood pressure?
The chapter states persistent readings where the systolic pressure, the top number, is 130 millimilli or higher, or the diastolic pressure, the bottom number, is 80 millimilli or higher, should be reported as hypertension.
But arguably the most critical BP assessment to master for older adults.
Oh, absolutely. Checking for orthostatic hypotension.
Explain that one again.
It's that sudden drop in blood pressure that can happen when a patient changes position, specifically going from lying down to sitting up or from sitting to standing. It's really common in folks who've been on bed rest or who are taking certain medications like vasodilators.
And it causes dizziness, risk of falls. How do we check for it properly?
It has to be sequential. You measure BP and pulse with the patient lying flat, supine. Then have them sit up, wait 1 to 3 minutes, and measure again. Then have them stand up, wait another 1 to 3 minutes, and measure a final time.
Okay, lying, sitting, standing, with pauses. What are we looking for?
You're looking for a significant drop, specifically a drop of 20 millimilli Hg or more in the systolic pressure, or a drop of 10 millimilli Hg or more in the diastolic pressure between positions. If you see that, it's orthostatic hypotension, and it needs to be reported and managed. It's non-negotiable, really.
Absolutely crucial for safety. Okay, let's move on to some of the specialized tools the chapter mentions for quickly assessing cognitive and psychosocial status. Sensory assessment seems pretty straightforward.
Yeah, a lot of it is just observational empirical data. Can they read the newspaper? Can they use a computer or phone? Do their hearing aids seem to be working? You can do simple functional tests, too, like the Snellen chart for vision or a whisper test for hearing.
But for psychological status, looking for confusion, delirium, dementia, we often turn to standardized tools.
Right, and the source specifically highlights the Mini-Cog. It's very well regarded, quick takes maybe 3 or 4 minutes total.
What does it involve?
It's got 2 main parts. First, you give the person 3 unrelated words to remember. Then you have them draw the face of a clock and put the hands at a specific time. Finally, you ask them to recall those 3 words. It's surprisingly effective as a quick screen.
Simple, but powerful. Now let's talk about the big systems. If you work in a long-term care facility or anywhere getting Medicare or Medicaid funding, you're going to know the MDS.
Oh, yes. The minimum data set, currently version 3.0, this came out of the Omnibus Budget Reconciliation Act of 1987, OBRA 87. It's all about standardizing comprehensive assessment using something called the Resident Assessment Instrument, or RAI.
What was the big deal with the 3.0 update?
A key change was mandating the inclusion of direct resident interviews, trying to make sure the patient's own voice and perspective were captured, not just filtered through staff observations.
So how does it work, basically?
The MDS data collection identifies potential problems called care area triggers, or CCATs. If a CCAT is triggered, say, for falls or pain or cognitive decline, it requires the team to do a more in-depth investigation called a care area assessment, or CAA.
Okay.
And that CAA then informs the development of the individualized care plan. There are about 20 different care areas covered, things like delirium, ADL function, pressure ulcers, nutrition, mood. It's very comprehensive.
It sounds like a lot. Are there quicker tools for bedside screening?
Yes, thankfully. The chapter mentions a couple of really useful acronyms for quick checks. First is SPICES.
By spices.
Yeah, it helps you remember 6 key risk factors that often signal functional decline or problems in older adults. S is for sleep disorders, P for problems with eating or feeding, I for incontinence, C for confusion, E for evidence of falls, and the last S is for skin breakdown.
Spices. That's handy for a quick scan. What's the other one?
The other is fan capes. This one's maybe a bit more detailed, often used for deeper focused assessment, perhaps in an emergency or admission situation.
Okay, fan capes. Break it down.
F is for fluids hydration status. A is for aeration oxygenation respiratory status. N is for nutrition. C is for cognition, communication. A is for activity, abilities. P is for pain. E is for elimination, bowel, and bladder. And the final S is for skin and socialization.
Fan capes. Okay, another good mnemonic. And finally, the chapter gives some clear guidance, sometimes in tables like Table 8.3, about when a change warrants an immediate call to the provider versus when it's serious enough to call 911.
That's right, critical decision making. Things like uncontrolled bleeding, chest pain that doesn't get better with nitroglycerin, new onset of seizures, or severe respiratory distress. Those often need emergency services, 911. Other changes might need a prompt call to the doctor or nurse practitioner. Knowing that difference is vital.
Absolutely. Well, that brings us towards the end of this really packed deep dive. We've gone all the way from just setting up the interview space to recognizing those tricky, atypical vital signs and using specialized tools.
Yeah, it's a lot to cover, but it's so fundamental. And I think the final synthesis, the big takeaway here, is that assessment isn't just something you do once on admission. It's got to be continuous, an ongoing process.
Mm-hmm.
And because nurses realistically spend the most time directly with older adult patients, they really hold the primary responsibility and the greatest opportunity to notice those subtle, critical changes. The ones that might signal something serious is brewing.
Catching things early.
Catching things early before they escalate into a full-blown crisis or catastrophe, that's the goal.
So as you, our listener, move forward in your practice, maybe reflect on this, really mastering these unique adaptations we've talked about today, like routinely checking for orthostatic hypotension, or truly understanding that a small temperature bump could signal severe infection, it fundamentally changes how you look at patient stability, doesn't it?
It absolutely does.
You stop just looking for the textbook signs, and you start actively searching for and recognizing those atypical presentations that are so common in geriatrics. And when you do that, you become a much more effective, much more powerful advocate for this often vulnerable population.
Well said.
Thank you so much for diving deep with us today.